I'm Dr. Dale McGee, Director of the New England History of Medicine Society, and today on Spoken History, we are interviewing Dr. Bill McDonnell, a dental anesthesiologist. Dr. McDonnell trained in the 1970s in dentistry as well as anesthesia. He practiced dental anesthesia in a very innovative practice from the 1980s until the 2010s. And also has served as an officer in the Connecticut Dental Association, the Hartford Medical Society, and a number of other organizations. Further, he has an interest in the history of medicine and dentistry, including Horace Wells, the discoverer of anesthesia. So let's listen to what he's got to say.
Hi, Dale. It's good to see you again. I'm
Yes.
Bill McDonnell, and I'm a dentist anesthesiologist. And most physicians and dentists really are not aware of dentist anesthesiologists for many reasons. But if you look at how dentists are looked at, in fact, I saw something on Facebook where a dentist said a patient came in and said, "I hate you because you're a dentist." And uh, oftentimes dentists will hear, "Geez, I hate going to the dentist. They hurt and everything else." Anesthesia really is not foreign to dentists. And of course, my hero is Horace Wells, who was the dentist who discovered anesthesia in 1844 in Hartford. And he was declared discoverer of anesthesia by both the American Medical Association in 1870 and the American Dental Association in 1864. And that was right in Hartford. And I may have mentioned that on my wife's and my first wedding anniversary, we went out to eat, and then we went to find Horace Wells' grave in Hartford. So I'm very romantic and really changed things. But anyways, she's, would remind me quite frequently that everybody thinks you're so nice, but they don't have to live with you. So anyways, but when we talked about this before, I started thinking about how I had mentioned to you how I got involved in anesthesia and dentistry. My dad was a dentist. He graduated from Georgetown Dental School in 1944. And in 1948, he actually took a 3-week general anesthesia course at a hospital in Cleveland. And I think it was St. Vincent's, but I'll have to look that up again. And he recognized that there was a need for anesthesia. And the dentist who graduated during World War II and before that, they only had Novocaine. Lidocaine really was not developed until 1948 and really didn't become popular by dentists until the 1950s. So the dentist did not have very good local anesthesia. Procaine was not that good. It only lasted 15 minutes. The dentist actually had their dental handpieces only went 4,000 to 8,000 revolutions a minute. Now, the old timers in the audience know that um, back then they had a belt-driven thing and it made lots of noise. And most procedures were done without local anesthesia, only for surgery, or they'd go to sleep at the oral surgeon to have a tooth extracted. So it really was very difficult. The needles they used were not one-time use, disposable needles. They actually had to sharpen the needles and do that. So it was really quite a challenge. And patients had a lot of difficulty with pain and everything else. The high-speed dental handpiece, which goes 250,000 to 500,000 revolutions a minute, didn't really become available until 1956 or 57, and it took a little while for that to be introduced. So dentistry was pretty difficult. My dad had a home office, and so I knew what that was like. And you depended on how the door closed to the office, whether you spoke at the dinner table, and so I learned about that. But I did learn from my dad that the 3 reasons people didn't go to the dentist were pain, fear, and cost. And I've been in situations where I could provide care at no charge for patients. and it really was a serious issue. So I had grown up with that underlying, and I had gone to college, was going to get drafted, and luckily got in the Army Reserves and basic training, and then came back, and I had the choice to teach middle school science and math, and I could have done research at UConn Medical School or be a drug detail salesman. And I thought, if I had to deal with mice and rats, I'd be talking to them after about 3 weeks. So I knew that was my personality. And so I took the job as a pharmaceutical salesman and met physicians and dentists and pharmacists and hospital practices and everything else. And I thought about going to dental school, and I'd applied
When
and got
was
in
this?
Georgetown. And this
When?
was 1972.
Oh, okay, great.
So there were classmates from college who were now freshmen in dental school. So got accepted and went down to trying to find an apartment or place to live in Washington and check out with my friends. And they said, "Oh, Mac, you don't want to come to dental school. They treat you like dirt. It's terrible. We study all the time and this and that." So luckily, I came back, and you meet certain people in your life that change your life. I met that person. So Monday morning, I was calling on Bill Lucy, who was a young oral surgeon in Bristol, Connecticut. And I said, "Oh, Dr. Lucy, I was thinking about going to dental school, but I don't know if I want to go. I have a good job and this and this and this." I said, I went down with all my friends. They said, "Oh, dental school is terrible. They beat you up. It's, on and on." So he said, "Put the sample bag down. Let me show you what dentistry is really like." So I watched him. And then every Saturday for the next 8 or 9 months before dental school started, I was his dental assistant on Saturdays and but all his patients got anesthesia. And he said to me, he said, "I take out teeth every day. If only somebody could put the patient to sleep and do the filling or the crown, which is what they need. But so many patients come in and say, I have to go to sleep. I can't do that." So he recognized the need for it. So I got down to Georgetown and met another oral surgeon who was a classmate of my dad's, Robert O'Brien, in Falls Church, Virginia. And he was really very sharp. He had built a dental surgery center in 1960 because orthodontic surgery was not a covered procedure for by medical insurance. So it was less expensive. He had a complete surgery center that had two ORs and rooms so the hospital rooms so the patient could stay overnight. So he really was on top of everything. So here I have two very bright, two very successful people who are saying there's a real need for anesthesia. Now, if you look back to 1972, usually anesthesia was limited to oral surgery. At the time, the oral surgeons were doing the surgery and the anesthesia at the same time. And they both said, "Geez, if you're going to be a dentist, you ought to learn anesthesia." So when I was a freshman in dental school, I would say to faculty members, "Oh, I plan to do anesthesia." And they said, "What, are you out of your mind? There's absolutely no need for this. You'll never make a living. It's waste." And I look back now 50 plus years and go, how could these very bright people say there's no need for this? And they were all wrong. And you look back and say, I wasn't the rocket scientist. They really hadn't done much research on dental anxiety and fear and everything else. They just, well, that's part of life. So when I was a senior in dental school, I was applying for residencies. And at the time, there were multiple anesthesia departments that had 1 year anesthesia residencies. At the time back then, the anesthesia residencies were 2 years. So people would do an internship year and then do 2 years of anesthesia. And anesthesia really was not a popular specialty for U.S. medical students. And that it didn't become as popular until you got into the mid to late 80s. So
Mhm.
they were looking for people who were somewhat bright and had good hands and knew how to take care of patients. So there were some of these residencies. So I got accepted at both GW and Washington Hospital Center, and
Nice.
for some reason I just liked the Washington Hospital Center people better. And here, the 1st of September, I get a note that their accreditation's on probation. I said, geez, I don't want to go to a program that's on probation. So I had met a dental student from the University of Pittsburgh, and he said, oh, Pittsburgh's got a great anesthesia department, and they have a good residency, and it was a 2-year program. So I said, well, geez, 1 year is good, 2 years has got to be a lot better. So,
Sure. That's what you did. Can I pause you a little bit?
sure.
Can we go back and paint a picture of your time in dental school?
Okay.
Not everyone knows what dental school goes like,
Okay.
and so just a
And,
picture of what it
sure.
constituted of.
Sure. At Georgetown, the medical and dental students are together the first 2 years. So take all, biochemistry and anatomy and everything else, and we would be in the same classes. Georgetown, as I recall, there were close to 200 medical students, and the dental class was about 135. And we were all together, and we were in labs together and everything else. So it worked out very well. When we became juniors, the medical students would go to the various hospitals and do their rotations. And in fact, my last 2 years in dental school, there were 5 dental students and 1 medical student, and we're still friends to this day. And we really got along very well and helped each other out and all those really good things. So once you get into the clinic as a junior, you're actually doing all the various procedures, and there's sort of a senior is helping out a junior and work together, so it works very well. Georgetown had a very good clinical program, and we treated lots and lots of patients, and we got down to DC General, and which was in a real difficult neighborhood and had lots of patients that came in. So it was really very good. So in applying, where most of my friends were either going to go into private practice as a dentist or do a specialty, periodontics, oral surgery. I was the oddball that did anesthesia, and I went to Pittsburgh and did that. So I had gone from 2 years in the dental clinics to all of a sudden being in the OR and starting from scratch. And I really had never been in that environment, unlike medical students. So there was a learning curve. But the University of Pittsburgh, Presbyterian University Hospital, Ioneer Hospital, McGee Women's, they really put the dental residents, anesthesia residents in, and we really got some great training.
So to clarify, in dental school, do you traditionally do an internship after graduating, or do you go right into
At the
practice?
time, probably 80% would do a residency, but at the time there was still a large number that would go directly into private
Okay.
practice. So now it would be very rare for somebody to go to dental school and go into private practice. So
Okay. And the other question is, when you were doing your anesthesia residency, was this general anesthesia
it
or
was
was it
general
dental
anesthesia.
anesthesia?
It was I was in with the medical anesthesia residency
Yeah.
residents, and we'd have a list, we'd have a room of patients to take care of, and for all kinds of procedure. I did not do hearts, but I did do a fellowship in neuroanesthesia. There was a neurosurgeon by the name of Janetta who did sitting cradiotomies, and the anesthesia in a sitting position is more challenging, obviously. So I was luckily able to do a fellowship in that afterwards. So
Excellent.
and so it really was very, very good. When I was finishing my residency, originally because of growing up in the Hartford area, anesthesia was, I would have done both the dentistry and the anesthesia at the same time. And after being in Pittsburgh and doing my residency, I realized that I could only do one well. I couldn't do both the dentistry and the anesthesia. So I decided I preferred anesthesia. So I applied to, there were 60 dental schools, and I wrote letters to each one and wanted to be 4 days a week teaching in the dental school and 1 day in the OR doing anesthesia, because that would keep up my clinical expertise and be exposed to physicians and nurse anesthetists who are doing anesthesia on a regular basis. That would help me keep more current.
Hmm.
So the University of Connecticut actually offered me a position, and I was 4 days a week in the operating room doing anesthesia for whatever came in, and 1 day in the dental school. So I was really very, very lucky. And I remember working with a neurosurgeon in Hartford. His name was Scoville, who was just, really well thought of. There were Scoville instruments. There were at the Hartford Hospital. There were ORs all set up just for him, and
Hmm.
he and I became friends. And he would ask. I was very flattered. He asked me to do special patients with him, and the question, he really had a profound statement. He said, people are usually down on what they're not up on. And I've always remembered that comment. So, why is a dentist doing anesthesia? And, there's a real need for it. So
Hmm.
I was there about 3 years, and we got a new chief of anesthesia, and he goes, what's a dentist doing anesthesia for? And so he really made my life a little miserable, but in fact, he did me a big favor. With that, I actually started a practice doing anesthesia for other dentists, and I would go to their office. Originally, I thought about setting up a dental surgery center and have the dentist coming to the surgery center, but the mentality of the dentist is, if you've gone to different dentists, each one has different handpieces, different instruments,
Oh, yeah.
different. So, unlike physicians who are used to working in the OR and work with whatever the hospital or surgery center has,
Hmm.
so I ended up being the one who was mobile. So I would go to different offices, and general dentists, periodontists, endodontists, occasionally oral surgeons, pediatric dentists, and I would do anesthesia for them.
Hmm.
And what had happened in Connecticut, I started in '83. It was very slow. I would go around and say, hi, I'm Bill McDonnell. I pump gas for a living. I do anesthesia. And they, there's no need for it. We don't have. So it was a challenge. And whereas on the West Coast in California, friends that were practicing out there became very busy in less than a year. So it was really the mentality. But my mother always said, she read my dad's dental office. She said, oh, Connecticut and New England's always slow. They're always behind. Anything new and different is always bad. So, anyways, it took a while. But then by the time I finished my practice, I'd work with over 200 dentists. And on Monday afternoons, I actually was at the dental school teaching dental students and residents, and I would do sedation for them to do various procedure. The dean, the late Jim Kennedy, and I talked, and he said, Bill, I have students and residents that need to learn about sedation, and you need an academic position. So, anyways, thanks to him, I got to do that. So, there are a lot of people who helped me out.
Right.
So, it was good.
Amazing. And as far as the kind of cases that you were seeing over your career, take it, let's say, from your
Sure.
residency to your retirement,
Okay.
how did that change, as well as a lot of advances have been made with regard to safety and monitoring in
Right.
anesthesia? How did you handle that and going from office to
Well,
office?
sure. If you look back to 1983, even the late 70s, for that healthy patient, even at university hospitals, we would use just a blood pressure cuff and a precordial stethoscope. The pulse oximetry really didn't become available until 1985, and I was working at one of the local hospitals, and we were trying out some pulse ox machinery equipment, and I said, "Now, which is faster, Bill or the pulse oximetry?" I bought the machine. It was
Mhm.
faster than I was. But if you look back to when you and I were starting, anesthesia was a lot different than it is now. So that really changed. And the other thing is that what was available for, I think my first electrocardiogram ECG machine weighed 55 pounds. So trying to schlep that around was a challenge. So now with newer, lighter, more efficient equipment, that's probably been the big change. And propofol was not available. That didn't come around until I want to say early 1990s, and we were using methylhexatol and pentothal, and we were using different agents. So really was uh, anesthesia was not as sophisticated as it is now, and patient safety has dramatically increased. But looking back in the late 70s, early 80s, I mean, we thought we were doing everything up to snuff, and in fact, we weren't. But things have improved.
Mhm. And now, how did the type of anesthesia a patient received in the office differ when you came on the scene? So, if a person was doing his own dental work and
Yeah.
anesthesia at the same time versus you being there, uh,
What
how did that
the,
pairing work?
the difference is, for the most part, I used uh, sedation or deep sedation. So a narcotic, some type of benzodiazepine, and something like either a barbiturate or propofol, and use that for the most part, because we did not have easy access to the inhalational agents. And in Connecticut, um, medical insurance paid for children and special needs patients to be done in the hospital. So I would refer those all to the hospital setting. In the early 90s, with what I like to call mismanaged care or managed care, all of a sudden they decided that the anesthesia in the hospital would come out of dental insurance. Well, dental insurance has been $1,000 or $2,000 max for the last 50 years. And as you know, to try and bring a child into the hospital setting, 20 years ago, it was, eight to $20,000. And what young family could afford to do that? So I actually worked with a pediatric dentist and an oral surgeon to get the bill passed in Connecticut so that if it was medically necessary, the medical insurance had to pay for the hospital, the anesthesia, recovery, and overnight stay, and all those things. So it took us a while to get that passed. But of all the accomplishments, I would say that's probably the most important thing. We helped lots of families, with young children, and if you think special needs patients, so that really made a big difference.
Mhm. And so you found yourself essentially innovating in a field in Connecticut and having to advocate for it with regard to the insurers and everything. That must have pulled you into the political scene a little bit.
It actually did. Originally, there were going to be new regulations for dental anesthesia. And at the time, I was working with about 40 or 50 dentists. And the initial rules wanted me to be inspected in each and every office. And unlike medicine, the dental regs were going to require me to put two patients to sleep in each office. So you
Mhm.
can imagine having to put two patients to sleep in an office, the amount of time putting a patient to sleep and waking up and recovery and all those things, it would probably take at least a good half a day or potentially longer. So it was really very, very difficult. And luckily, there was an old timer, Mike Cesaro, who was actually a dental commissioner, who said, "Wait a minute." He asked the oral surgeon, he said, "What do you have to do?" "Oh, you get to put two patients to sleep in your office, and then that's it." "Well, if you only have to put two patients to sleep, Bill only gets to have to put two people to sleep. But it really, I ended up being on the board of the Connecticut State Dental Association and ended up being president of the State Dental Association. And I had a friend, Sal Squattrito, who said, you have to watch malpractice insurance. You have to watch rules and regulations, and so you might as well get credit for it. So he's the one who got me to go on the board of the Connecticut State Dental Association, and it really was. I found it to be very good. I met a lot of very interesting people, and we got some bills passed that actually help patients and improve things. So it was very rewarding.
Wow. Yeah. Now, on a typical day, sort of how would it go? I mean, what was a
Well,
typical day for you
what
in clinical
happened
practice?
is I would usually be in two offices a day, usually, and I would be in one office, and we'd start like in the OR, we could start, 6 to 8 in the morning, and what happened is, with periodontal surgery, gum surgery, periodontal disease. The tradition is somebody had full mouth periodontal surgery, they would do one quadrant at a time. So do one quadrant today, 2 weeks later, come do another one, and then so it's four separate times. So one of my roommates had a patient who had periodontal disease and needed to have the surgery. So he said, "Well, look, either get beat up 4 times or have Bill come in and get it all done at once." So what happened is, when you're doing open heart surgery, you're not going to do one vessel this week and then come back next week, and that. So there was a mindset to get the dentist or dental specialist to be aware of that. So it really changed things. It made it much easier for patients, and think of things that are done, medical procedures that are done with anesthesia, and nobody gives a second thought. Whereas dentistry, oh, you don't need it for that. But dentistry can be very uncomfortable, and it really makes a big difference to have that as an option. I mean, it's not for everybody, but it's an option. So I would be in one office in the morning. It could be general dentistry, or could have been a child, or could have been a root canal, or could have been any one of different things. And in the afternoon, I would be someplace else, and it would be another procedure. So it was really good. And then, as I mentioned, Monday afternoons, I'd be at the dental school working with the residents and the students.
Hmm.
So
Hmm. And were most of the dentists that you worked with in solo practice, or were there larger groups?
uh, it's starting in 1983 in private practice. The majority of dentists were in private practice. There were only a very, very few multiple practitioner practices. Dentistry probably is 15 or 20 years behind medicine. And from that standpoint, whereas you'd be a lot of solo practitioners, and that was very common.
Hmm. And did you did you find that the types of procedures, you said that they would take multi-stage procedures, but with you being available, they could then turn it into a single stage procedure.
Right.
Were you involved with the majority of the patients that they were working on, or were you involved in a subset that tended to require deeper
Well,
anesthesia? What was that subset?
okay. I think if you look at the root canal specialist, the endodontist, if you look at the periodontist, you look at those practitioners, they really would give the patient the option to have it done with local anesthesia alone, or with some type of sedation, either nitrous oxide sedation or some type of oral sedation. And they would give another choice of having me come in and do the anesthesia. So what I found is that the practitioners that offered all the options to the patients, I would see them more frequently. And like physicians in the OR, I would have certain people that Wednesday was their operating day, and they really preferred having me there. It made it easier for the patients. It made it easier for the dentist or dental specialist.
Hmm. And so I'm trying to imagine how inhalation anesthesia goes when you're working on someone's mouth.
Well, the key is obviously the airway. Trying to have an endotracheal tube in, an oral endotracheal tube in, and do a dental procedure is a real challenge. So obviously, if a patient needed to be intubated, we would use a nasal intubation.
Mhm.
But if the other key is if you could do sedation and the airway was secure, you could go ahead and do it that way. So we found that a large percentage of procedures could be done, especially with adults, could be done with sedation or deep sedation.
Great. And over the years, besides there being advances in the safety equipment that was available and the fact that they're a little more compact
Right.
and accurate and the like, did you notice any other changes that were occurring in your
Well,
field?
well, obviously with infusion pumps
Hmm.
and those, I mean, it really changed. And I've been out of practice 7 years now, and what's happening is the new young dentist anesthesiologists are much more sophisticated than I was, and they are using the latest, and they have the latest equipment and monitoring and everything else, and it's really amazing. Uh, Doing general anesthesia when I was doing initially for children was really a challenge. And doing inhalational anesthesia in an office, it really had to be set up for that. The ORs had to be bigger and all those things. So there were times that if I felt a patient would do better in the hospital setting, I would cancel the case and send them to the OR and do it that way.
Hmm. Hmm.
But now what's happened with the equipment and the smaller anesthetic machines and everything else, they're doing much more in the office setting. In fact, I met someone who was, pardon me, building a dental surgery center and doing lots of pediatric cases. So it's really changed dramatically.
Hmm.
And the agents are much better now than they were years ago.
Uh, and you said that really, from a point of view of forming larger groups, that doesn't seem to have kept pace with what has happened with those in general surgery or general medicine. And
Well, go
and
ahead.
what
I'm
about
sorry.
institutions trying to, buy up practices or anything, or
Well,
or even private equity?
it's that's really changed dramatically in the last 10 years. There's lots of private equity taking over practices, and it's I think it's a little sad. I know people who have sold their practices, and all of a sudden they lose the control over the patients. I got approached by an anesthesia department, I guess about 14 or 15 years ago, and yeah, I was really flattered here. A medical anesthesia department wants to take over my practice, and at the same time, my poor wife had has cancer, had cancer, and she passed away. And all of a sudden, I thought, geez, I like what I do, and my wife needed me, and I thanked them for their interest, but um, I decided not to do that. But I
Hmm.
do talk to uh, dentists or physicians who all of a sudden they're part of the corporate world or um, venture capitalists, and all of a sudden they get dictated to as to what they can do and how many patients they have to see and all those things. And it was a nicer position to be in if I wanted to do pro bono or I wanted to take care of someone. I could do that, and if I didn't want to bill somebody, I didn't have to. And it was. And if a dentist would say, "Geez, Mary Smith is really has a hard time. Could you take care of her? And I could do that, and
Yeah.
my dad was a dentist, and he took care of all the nuns at the convent. And there was this one family, the dad passed away, and there were four kids, and my dad took care of all the dentistry. He's rolling in his grave for me even to mention that. Took care of the whole family until the last son graduated from college. So,
Hmm.
I think that's one of the nice things that in medicine and dentistry we can help people in different ways.
Right. Terrific. And in thinking back with regard to your career, um, is this a field that you would advise people to go into today?
I really would. It's interesting when I had a stroke and all of a sudden couldn't work anymore, and I had a list of patients and offices and everything else, and luckily I found a nice fellow who I helped get started. In fact, he was, and I referred all the children out to him. I just said he'll take care of our special needs. I think as we mature, there's certain things we say, I need less stress in my life. Let's get somebody who's really good at take care of it. So he was kind enough to take over. And then he's had health issues, so we have a bright young fellow who finished up his residency, and he's taken over the practice, and it's really becoming much more popular. And he now has three dentist anesthesiologists with him. So things have really changed. So
Yeah,
uh,
they can
uh,
move around.
yeah,
And they're still moving office to office, case
right,
to case, couple of
right,
days.
right.
And do you do you feel that a anesthesiologist who has had medical but not dental training could do your job,
Uh,
or do you feel that
of course they could do it. That's not the issue. The
mm,
only thing is having been a dentist, there's certain nuances to make it easier for the dentist.
mhm,
And if you're doing medical anesthesia and obviously the oral cavity, as you mentioned earlier, I think I could anticipate what was going to happen next, and did the patient need to be deeper or lighter or those
mhm,
kinds of things. And like anything else, if you get used to doing anesthesia for ENT procedures or neurosurgery, you become more astute and better able to help the patient. So,
mhm,
but it's interesting that in the 80s, very few physicians, anesthesiologists, wanted to leave the hospital setting and go to an office. And I can remember talking to an anesthesiologist who was chairman of one of the departments in the area, and I said, geez, you should really branch out and, plastic surgery and ENT and, different procedures that can be done very easily in the office setting rather than the hospital. And, I talked about it. I said, here, let me show you what I do and the equipment I have and this and that. And they thought about it, but they didn't really go ahead. Now I think that's starting to expand, which it should. I mean, um, it makes it easier for patients. They're going to be
mhm,
more accepting of having procedures done, and both for medical procedures and dental, there's a certain fear factor. And if I can have a procedure done safely at my physician's or dentist office, it really makes it much easier for the patient. So.
mhm. And with regard to the kinds of procedures, I mean, going from fillings to crowns to implants and things like that, how has that evolved over your
Well,
practice?
initially, as I mentioned, most anesthesia in the early 1970s and 80s, a lot of it was oral surgery. And then all of a sudden, you start thinking restorative dentistry for a patient that I did hadn't been to a dentist in 25 years. When he was in the
Mhm,
Coast Guard, he'd broken his jaw, and they removed the wires without anesthesia. And this man was the nicest guy. He was just terrific. And So he had to have some extractions and had to have some fillings and some other things. And then he had me every 6 months to put him to sleep to have his teeth cleaned. And I'd say, now look, David, you don't need me for that. I'll tell you what, I'll start the IV. If I don't put any medicine in, I won't charge you, you know. No, Bill, if you're not here, I'm not here. So it was, I mean, I encouraged and I would tell patients, okay, you haven't been in the desk in 15 years. All of a sudden now everything is fixed. You're in good shape. Come in every 3 months to get your teeth cleaned, and you won't need me ever again. And
Yeah.
there were patients who did that and never needed me. And I can remember one woman that I met years ago when I first started, and she was able to go to her dentist every 3 months and never had to have anesthesia again. And then there are other ones that would disappear for 3 or 4 or 5 years, and oh, I'm back again. And I'd say, I try and encourage them to go in, but it's everybody's different. So.
Yeah. Well, it's been a good career.
It really has. I look back and I have to thank my dad, which is sometimes difficult because he recognized the need for it. But more importantly, Bill, Lucy, and Bristol. You meet certain people in life that change your life, and we still exchange Christmas cards. And a few years back, I sent him a note. I said, had I not met you, I never would have done anesthesia, which I liked. But
Hmm.
because of you, I ended up doing my residency in Pittsburgh. I met my wife there. I have 4 children. I now have 5 grandchildren, all because of you. So,
Yeah.
it's really good. And I working with over 200 dentists. I like to think I help them do things they couldn't do before and
Right.
help patients out. And it really got to be friends with lots and lots of dentists, and I learned a lot, and hopefully they learned a little bit, and we helped a lot of patients out. So that's the best thing. And like anybody else, I had tough days, and I go and say, but just try and do your best every day.
Hmm. Excellent. Well, has been a terrific conversation, but I want to talk to you a little more about your hobby of medical history because
Ah,
you really got something to
well,
say there as well.
that gets to be a lot of fun. I um, grew up in Hartford,
Hmm.
and I didn't realize, but when I was a senior in high school, I sold women's shoes at Baker's Shoe Store in downtown Hartford. And I used to pick up a bus, and there's that bronze tablet to where Horace Wells discovered anesthesia. I didn't know that until years and years later. But when I was a resident, there was a Dr. Harry Archer who was one of the premier oral surgeons in the country, and he was head of the department in Pittsburgh. But when you were back then, you were a resident, he was moving offices. So I got to be a schlepper and move books and everything else. So he actually had written a lot of information about Horace Wells, and he gave me a monograph that he had written about Horace Wells, and I actually still have that. And as I mentioned, I saw Horace Wells' grave on our first wedding anniversary. And then what would happen is there was a restaurant in West Hartford, 36 Lewis Street, I'm sorry, in Hartford, and that had been Horace Wells' home at one point. So anytime anybody in anesthesia came to Hartford, we would always go there for lunch and talk about Horace. So because I was the local guy, I got more interested in him. And there's a Horace Wells Club that was founded in 1894 on the 50th anniversary of discovery anesthesia. And there's 40 members. Somebody has to die so somebody could come in, and I got nominated for that. So I would learn more about Horace Wells. And then we had Lenny Menzer, who actually started the Hartford Medical Society uh, Museum, which actually had Horace Wells' Day Book, which was the record of patients he treated, and had lots of different things. So that led from one thing to another. And the Horace Wells statue in Bushnell Park um, was in 2000 really needed to be restored. So because I could see somebody early in the morning, or I could stop by the park early, I started stopping by to see, and I found out about how you restore statues and all that stuff. And then the Horace Wells grave in Cedar Hill Cemetery was paid for by his son Charles, and it's bronze. You've seen it. There's the Angel of Mercy bringing the vapors to the patient in
Right.
pain. And on the sides are those two beautiful angels. Well, they got stolen in the early 1980s, and I got somehow they found my name, so we actually raised $55,000 to get that restored and get the two angels replaced. So
Wow.
that and I ended up being on the board at Cedar Hill Cemetery, and one thing led to another, and it's been fun trying to make sure everybody realizes who discovered anesthesia. Sometimes people forget. So,
Right. So is your focus exclusively on Horace Wells, or are there other parts of history that you?
well, anything that's related to Hartford and things in Hartford. Uh, J.P. Morgan was born here in 1837. Katharine Hepburn was born in Hartford. They're both buried at Cedar Hill Cemetery, and Sam Colts and Hartford in the 1890s was the Silicon Valley of the United States. It was the wealthiest city, and there were lots of really neat, very interesting things. So anytime there's something going on, I try to see if I can learn something. So it's turned
Right.
out to be very good. And the Connecticut Historic Society, when the Hartford Medical Society closed their museum 20 some odd years ago, I made sure that the Horace Wells collection, including his day book and several other things, are now at the Connecticut Historic Society.
Uh,
And what's happened over the years, if there's a special group that comes to town, the pardon me, the Connecticut Historic Society will put together a display on Horace Wells things. And I mean, actually, to see Horace Wells' day book
oh
that,
yeah.
yeah, I mean, it's in his own handwriting and everything else. So I get carried away. Um,
Excellent. Well, this has been a tremendous discussion, covered an awful lot. It's been a pleasure to talk to you, and I really appreciate your taking the time to speak with us today.
Dale, thank you very much. I really enjoyed it.